Welcome back to the session. This is a very interesting session about case discussion, case review. These are cases from lung cancer practice or lung imaging practice, but overall chest imaging practice. You will find more than just nodules, I think. We are pleased to have our colleague Doris online. We are so sorry you could not be here, but thank you for making it to be here with all of us, at least on the screen. She's providing many interesting cases, and actually she was supposed to be the moderator, and I'm taking her place locally, surely not at the same level, but I'm trying to chase. So the co-chair today is Dr. Jelitto Markozata. She's local from Gdansk. I'm letting her the word.
Good afternoon, everybody. It's a very great honor for me to be here and speak to us. I also have 4 cases for you, and they will be quite challenging, not only lung nodules, but you will see it because first Professor Dorit will be first, and I'm the second one.
And let me briefly introduce you our great team of panelists. So we start with pulmonologists. A warm welcome to the pulmonologist on the panel of radiologists, Professor Seijo from Spain. He's a pulmonologist. You've seen a great experience in lung cancer screening and so interesting discussion about COPD. On the second chair, we find Dr. Sorry, can you pronounce that, please?
The Dr. Katarzyna Sienkiewicz.
Okay. Yeah, I'm sorry. She's a radiologist with specialization in heart imaging. And we have Dr. Kerpel-Fronius from Hungary. She's a chest radiologist. Professor Kazerooni from the US, and she's a chest radiologist too. And from the Netherlands, Dr. Gratama, chest radiologist involved in the foreign long-run lung cancer screening. I think we are at the all-star game here, more or less. So let's get it started. I'm giving the word to Doris. The floor is yours.
Hello, everyone. So again, I'm really sorry that I cannot be there, but I hope that you will like the cases that I'm going to present today. You can scan, please, the Mentimeter so you can participate. Okay, you will find it on the polling questions as well. So we already introduced the panel members. And the first question is the warm-up questions. How long have you been attending the Agile conferences? Is this your first time, second time, or have you been to all 3? So okay. Okay, so we can see that for the majority, more than half of the people, it is the first time. So the cases that I'm going to present today are from my hospital in Jerusalem, Hadassah, and there are dilemmas that we had in our MDT meetings. So first case. So I'm going to present 4, and my colleague, Dr. Jelitto, is going to present the next 4. We decided it will be 20 minutes for each. So after 20 minutes, I will stop, no matter how many cases I can do. If I have more time, I have more cases ready. So first case is a 40-year-old male, healthy, non-smoker. He has no occupational exposure. And in 2020, January of 2020, he underwent right middle lobe lobectomy for lung cancer. Okay, so please look at this video. Okay, so so the first question relating to this case is, what would you recommend as the next step? Is it 1 to 3 months low-dose CT, 1 year low-dose CT, clinical pulmonary evaluation, or comparison to previous CT scan? Okay. So I see that most of you chose to compare to the previous CT scan. Great majority, okay. And this is indeed what we did. So now I hope this will, okay. So you can see here, it's only one place in the right lower lobe. You saw that these findings were very diffuse over the lower lobe. And you can see that the findings have increased. So hardly nothing in 2024. Then in 25, a little more. And in the most recent one, February of 26, the findings increased a lot. So now what would you do? What would you do now as the next step? Is it clinical evaluation, bronchoscopy, CT-guided needle biopsy, or again, comparison to the initial imaging of this patient? Okay, so it's really the percentages are changing rapidly. So I see that the majority would like to do bronchoscopy. Some people would like to do CT-guided needle biopsy, less people, and only 9% would like to compare to the initial imaging, which was okay, so this is the question that we already have. So now we decided to compare to the initial imaging. Remember that this patient underwent right middle lobe lobectomy. Some of you who were in the first Agile meeting may remember that I showed this case. It was, of course, the more recent ones were not available 2 years ago, but I showed this case. This was actually the initial cancer that this patient had in 2019. And here you can see the preoperative before the right middle lobe lobectomy. And this is actually what it looked like. And if you will look carefully, you can see that already had some of these findings back in 2019, before his surgery, which was in January 2020. These were the results of the right middle lobectomy of the time. So it was mostly lipidic adenocarcinoma. There was spread through air spaces. And the staging, the pathologic staging was T2 and 0 MX at that time. Okay, and now we go on to the questions to the panel. So we are now at this point. The last CT that I showed you was something like a month ago. And I will move it over to Mario. Okay, so my question is, what would you do now? Now you know what the initial cancer looked like. You know that what we have now already started then. And another thing that I have to tell you, and that they took during the surgery, they took a biopsy from one of these findings in the right lower lobe, and it was similar to what was in the right middle lobe. So do you think a rebiopsy is necessary? What would you do? Did any of you see a case like this?
Thank you, Doris. I think this is time for the panel discussion. Luis, do you wanna take first word?
Just a couple of comments. So bronchoscopy is a very general term that obviously there are multiple options there. So I would even potentially consider getting a PET-CT scan to see if there are any lymph nodes involved. I didn't get to see the mediastinum there, but considering this might be progression or even metastatic disease, and you know, if you have lymph nodes involved, that might make it very easy to get an EBUS and also get a molecular analysis on that. If not, then I think bronchoscopy is a good start, whether it's just a lavage, which might be very helpful considering it's all airspace dissemination potentially, so that would be accessible to a lavage. But that's the crudest form of bronchoscopy, so to speak, nowadays. We would potentially have navigation and other tools to get a biopsy there, including cryobiopsies of those areas to see if there's disease there.
Yeah. Helen, you or Anna?
I would completely agree. It looks like the pretest probability of this being multifocal adenocarcinoma is very high. I'm not sure that we would treat without having a confirmation of the diagnosis, though, just in case you're missing some sort of an atypical infection. But I think diagnostic confidence is pretty high that this is multifocal adenocarcinoma.
Yeah, I see Anna.
And probably the only reason behind a biopsy is to see whether there's a driver mutation, because that would, for me, one of the questions that we will be discussing this is, Ella, so this patient did not get any treatment after surgery. So
No, he did. He did. And
okay.
I'm not sure what was the driver mutation, but it was known, and he had targeted therapy.
Yes, but still, I think you would have to look for, because maybe there is a new mutation that is treatable, which happens in these cases. So that's why I would go for a biopsy, not necessarily to confirm the diagnosis, but to get a more precise diagnosis.
Okay.
Yeah, we were lucky to have the first CT scan. We can see the morphology, and there are some patchy spaces, and some of them look like the first tumor. And the development of the pattern in the right lower lobe is very slowly. So I think then atypical infection is on basis of that slow progression less likely. So I think a biopsy, it's a little bit diffuse in the lower lobe. So I think the suggestion of the PET-CT to see if there are lymph nodes where you can take a biopsy is a very good one.
Kasia, what's your opinion about this? I think you agree with the remainders. So Doris, we have had the full round of panelists.
Okay, so we will move to the next case. So this is a 73-year-old male with 50 pack years of smoking and shortness of breath. So he was sent to do, because of the shortness of breath, he was sent to do a chest CT, and this lesion was found 28 by 13 millimeter nodule, which is adjacent to the fissure. And I think I have to go to the next slide to see the video, to show you the video. So you can see the shape of this. So what would you recommend as the next step? Is it 1 to 3 months low dose CT, CT guided needle biopsy, PET-CT, or comparison to previous CT scans? Okay, so almost half of you, more than half, would like to do a needle biopsy right away. 28% say comparison to previous CT scan. Okay, percentages change a little bit, but we will go on to the next slide. So when we look at the previous CT scan, this is what we see. Okay, so this was January of 2022. This was in February of the same year. So now that we know what the previous CT scan looked like, what would you recommend as the next step? Is it 1 to 3 months low dose CT, 1 year low dose CT, PET-CT, or CT guided needle biopsy? Okay, so the majority would like to do 1 to 3 months low dose CT. Some people think we should leave it alone, just do 1 year low dose CT. PET-CT is 15%. Okay, so what we actually did was PET-CT, and these are the findings. So there was an area which was, the SUV max was 5.9. So do you think it may be perhaps carcinoma in scar, taking into account that before there was a consolidation there? Okay. So what would you recommend now? Is it 1 to 3 months low dose CT, PET-CT, CT-guided needle biopsy, surgery? If we, most people thought maybe 1 to 3 months low dose CT, if it stayed the same, how do we now, what do we think about the results of the PET-CT? So 70% think CT-guided needle biopsy, 22% surgery at this point. So what we actually did was needle biopsy. And the result was very surprising. It was aspergillus. So it was a focus of infection, likely within a scar. And I remind you that this was a heavy smoker. So when I reviewed these cases with Mario last week, he asked me if there was aspergillus back when he had this pneumonia. And so I didn't think to look it up when I prepared the case, but actually he had a sputum evaluation during this episode in 2022, and there was aspergillus and candida back then. So these are the questions to the panel. Have you ever encountered a similar case, and how would you have managed this case?
So we now move to the panel. We can probably start from the back and down proximal.
Yeah. I have not seen a similar case like this. I thought because the changes in the time that would have been an infection, but after a month there was still some remnant. Yeah, you could do a clinical evaluation, but that wouldn't give a diagnosis, I think. Sputum analysis, I don't think that's nowadays done. So I would have done the second scan and look clinically at the patient by the pulmonologist, and then seeing the persistent, more focal lesion, I think I would do a PET-CT, and then you could have done a bronchoscopy. Maybe you could have found a diagnosis by that, and otherwise I would also have a transthoracic biopsy.
I think similarly, you're stuck in a difficult position. If you didn't have the first imaging, you'd be highly concerned about cancer, potentially even extending along the pleural surfaces. With that history of infection, you really don't know which way to go. Some of this has to do with, talking to the patient, what is their risk threshold for watchful waiting versus going on to do something to establish a diagnosis like bronchoscopy. So I think there's not a right answer as to whether you pull the trigger on a bronchoscopic biopsy with lavage, or whether you go to CT-guided biopsy versus doing another watchful waiting, depending on the patient's tolerance for risk and risk of cancer.
So pushing it to the extreme, would you have avoided even that PET-CT?
Well, knowing that he had aspergillus infection, and that aspergillus can be nodular, and it's in the area of infection, I don't think it has the same pre-test probability being cancer as if it was in the normal background lung. And not knowing how he was treated, what kind of medicines did he receive, how quickly did it respond.
So I haven't had a similar case. My only question is really, after such a huge infection, are we sure that PET-CT was the best next step? Because in infection, PET-CT will have will have activity. So I would definitely not have gone for PET-CT, because once the PET-CT is there, you have to treat it. The probability of it being cancer is actually higher in all the models. I would probably have done, what I would have done is ask the patient to come back in 6 weeks or whatever after antibiotics or pulmonology consult for infection, and then do a recheck. And if it's still persistent, then I would have went for CD-guided biopsy myself, and probably wouldn't have done a PET-CT. That's my take on this case.
So we see this
okay.
not often, but sometimes with these major infections that you see these different variants, I would call of rounded atelectasis, where you have, it's on the fissure there, and you get these residual nodules, or whatever you want to call them, and these keep us up at night, because there is no way to know if there's a cancer underneath that. If you get a needle aspiration and you get this sort of non-specific inflammation, then you don't have the certainty that it's just infection and that there's not a cancer underneath that. And we tend to follow these for a prolonged period of time and just never feel comfortable until several years go by and you see that these images either get slowly smaller or don't progress. And then that's how you know you're okay. But they keep us up at night because we don't know what to do with them. And we're fairly confident, because it shrunk from the original infection, that it's something residual, but it's a tough call. I like the PET because I think it does give extra information, not just about the nodule, but if you see lymph nodes or any other findings, that might help you in terms of going after a diagnosis.
I want to give, okay.
Dorit, there is a question from David.
Yeah, I can't hear. Can you please repeat the question? I couldn't hear it.
Yeah, my question would have been, let's say they had done the 1 to 3 month follow-up, and now it came back unchanged. That would be, because that's the situation. I would not have done a PET scan. I think PET scan is just too much trouble, more trouble than it's worth most of the time with solitary, with nodules. So now it's going away. Now you get the 1 to 3, the 3 month follow-up, let's say, and this thing stayed stable. Didn't shrink anymore, didn't get bigger anymore. That, to me, that's the challenge I always face. What do you do then? Do you now wait another 3 months? Do you say, well, maybe now I should do something more invasive? That, to me, is the trickier situation. So I'm just curious what you guys would have done under those circumstances.
Actually, I think what both of you actually said, that you really have to have the patient's take on this. So there are a few patients who would say, I am in for watchful waiting. And there are a few patients who would say, I don't like it in me, please take it out or do a biopsy or whatever. So I think this is really a place where you have to communicate with your patient, because I think watchful waiting would be a good solution, but also getting definitive histology would be a good solution as well. So this is...
So in your mind, it's an equal?
For me, it's yes.
I would say if there's no change with watchful waiting, then you've proven that your choice was correct, and then you keep waiting. Yeah, but closely. Yeah, that kind. Yeah, I wouldn't wait a year to follow this thing. Yeah.
You wouldn't want this patient to be lost to follow-up and not be watching and surveilling.
That's why you have to know your patient.
Just a quick question.
So everybody's...
Yeah, I think also a short follow-up, 3 months or so, but the patient should come back. It's a heavy smoker.
So everybody's comfortable with continued follow-up after that point. Good.
The surgeon.
So, yeah, the surgeon. Hello. I'm a thoracic surgeon. So, judging from the result, you probably, not absolutely certain, probably have made the right decision. So I have two things to say. One, have you discussed this case with thoracic surgery? One. And two, there is a traction in there, in the lower lobe, so it can mimic lung cancer. If that was the case, we would be seeing someone going for just a lobectomy to a pulmonectomy. So judging from the result, you did take it was the right call. But the question here, in my opinion, is not what we managed to save, it's what we might have lost. So I would go for the PET-CT, then I would discuss it with thoracic surgery. Okay, he was lucky enough, it seems it was aspergillosis, yeah, okay, but it could very well not have been. And if that traction invades the other lobe, we are looking at an operation that doesn't have a 2% mortality, but it has in between 6 to 8% mortality. Let's make a translation to that for those who are not in thoracic surgery or in cardiac surgery. If you have a bypass, a coronary artery bypass graft these days, a two-graft thing is like 1%, maximum 2% mortality. A pulmonectomy has like 4 to 8 times more. I'm sorry, I'm thoracic surgeon. Thank you.
Okay, I would like to say, yes, I would just like to say that this was actually a patient of our thoracic surgeon who brought it to the MDT discussion. And he was thinking that it's likely to be a scar and maybe let's leave it alone. And then the MDT recommended to do the PET-CT and this thing started rolling. Okay, so my time is up. So I will pass it to my colleague, Dr. Jelitto, to present her cases.
My first case is a 69-year-old male with a history of 25 pack years, and now currently he is non-smoker for 10 years. He also have previous medical history of myocardial infarction on 2014 and prostatectomy on 2019. So he was a participant of lung cancer screening program, our national one, and on the first round we found such a lesion. I would like to highlight that here you can see the traction bronchiectasis, and here also, and on the sagittal view, the lesion is quite flat. This lesion was considered as a post-inflammatory scar, and this patient was qualified to further follow up in annual screening. So, oh no, I just... now, what would you recommend as the next step? I already said that what we did, but maybe you have different opinion, because I go too far with talking. What is your opinion? Maybe different than mine? I said too much at the beginning, sorry. Oh yes, some different answers, please. Okay, we have different opinions, fortunately, and also the follow-up after 3 months, because it could be inflammatory lesion. But this patient was observed in the annual screening. This is 1 year later, in 2022. The lesion still has traction bronchiectasis. And also here, the little ground glass opacity appeared. And still it is very, oh my God, here is still very flat on the sagittal view. And there's a sign of lung loss here. So the fibrosis is still present there probably. So still this patient go to another screening round. And after 1 year later, we have this lesion looks like that, still the quite huge traction bronchiectasis, also still flat on the sagittal view, but here you can see that also we have some bigger ground glass and some solid nodule which is here. And here I have slides which show shows the differences in size. Here, the lesion progressed during these 2 years from 2.6 centimeters to 3.2 centimeters. And I want to also highlight the appearance of solid nodule on the ground glass. And also I want to focus your attention on the traction of the fissure, which is still on each slide is more prominent, which is visible here, very prominent. And now is the second question for you. What would you recommend it as the next step? Options are like contrast-enhanced chest CT followed by CT-guided biopsy, bronchoscopy, yes, someone chose it, CT-guided core needle biopsy, or PET-CT.
Surgery. Surgery.
Not an option. Okay, we then go further. So, no. We are aggressive in this hospital, so we perform the biopsy. And here should be the first slide which appeared at the beginning, because we also performed the contrast-enhanced CT, which confirmed the high vascularity in the site, and also showed that there, near the fissure, here there was a slight line of nodularity, which I aimed with this needle. But unfortunately, the biopsy result was non-diagnostic, no cancer was proved, so this patient was enrolled to PET-CT scan, in which we saw only slightly elevated FDG uptake, but finally, as you wanted at the beginning, the surgical excision with frozen section was done, and during the frozen section, non-small cell lung cancer was proved, and after that, the patient had a right upper lobe lobectomy, and final histopathology was invasive non-mucinous adenocarcinoma, lipidic type, and also here there was visible central fibrosis and elastosis. Stage was PT1C and 0. And now, here's the questions to panelists. What feature would arise suspicion on malignancy in this case and help distinguish between a bizarre-looking scar and malignancy? And would you also choose to observe this lesion or proceed with a diagnostic workup? That's my question to the panelists.
Yes. For the very first CT scan, I think the problem was that in the sagittal or coronal reconstruction it was very flat, but in the other directions you saw the ground glass appearance, and so I think one maybe a little bit architectural distortion, that you saw a little bit tension on the fissure. So maybe there was some bronchopathy also. Maybe you could do a follow-up scan for 3 months, but you don't know if it's an adenocarcinoma. It grows very slowly. And then I think at the second scan, a year later, we clearly saw the traction on the fissure. So then I think you must think of an adenocarcinoma with lipidic growth. And then more diagnostics, I think, or surgery.
Yeah, I think similarly, the first case with the traction and the bronchiectasis might have led somebody to say, oh, this is scar. And the fact that it was flat, because it's against the fissure, it's more likely to be flat if it's hitting the fissure and growing along that direction. But there was a solid component, a dense component around the edge. So I think short-term follow-up was a reasonable thing to do. But once it started to grow then and there was more of that solid component, we would have probably gone to bronchoscopy, plus or minus PETs before that. And not waited till the third one.
Yes, I wouldn't have waited for the third one either. And the problem with biopsy, we have to do a lot of biopsies on patients like that as well, because for some reason the surgeons are really adamant, and then some. But most of the times these lesions don't, even if you are really in the middle, won't show up clear signs of malignancy. So that's always a difficulty. So I probably, me neither, I wouldn't have waited for the third CT, because you could see growth and you could see that that the fissure is affected. So that's always that's the worst part of. This is a sign that you have to look for, in my opinion.
I would add to that so partially solid is much worse than anything else. So that's already a problem. It's upper lobe, so that's already worse than anything else. Speculated in part, and also with the retraction. So, but the growth is key. So once you see that growth, I don't see how anything else is going to make you comfortable that this is not a cancer. And so that was the surgery part, just going straight to surgery.
Would you recommend a further diagnostic workup or surgery?
No, we would have gone straight to surgery, yeah, because you get a non-conclusive biopsy, and then that might muddle the discussion in the tumor board, and then people will say, watchful waiting because it was not conclusive, and then it just gives you a false sense of security that but the growth is so key.
And the fissure.
Yeah.
Yes.
It's an ugly looking lesion.
But fibrosis also can track the fissure and could cause the irregularity on fissures. So let's switch to another case. This one, now we have a woman. She is 62 years old, and she was a participant in our first lung cancer screening program in Gdańsk from 2009. She is a former smoker, 25 pack years. And now, on the time of the screen, she was currently non-smoker, almost 20 years, and had no symptoms. Now, here you see her abnormalities. We have several different things here. What you can see, it's a kind of cyst here. Here also, you can see ground glass, some kind of bizarre shape opacities here, like that. And what else we have here? Something even different and even more interesting. It looks like here like grapes of cysts. It's called bubble-like radiolucency. And here you also see some kind of ground glass areas. Yes, and now there's also on this window, mediastinal window, we see some enlarged lymph nodes. And now I would like to ask you, what would you recommend as the next step? 3 months follow-up, CT-guided lung biopsy, VATS resection of one of the lesions, or PET-CT?
Bronchoscopy.
Yes.
Of course.
Can I just make a comment? So the lesions are so heterogeneous that I don't know what you would go after if you went after one specific thing. So that's the biggest concern. There's so much heterogeneity in the different, there's some cystic stuff, there's some clearly inflammatory sort of broncholytic stuff, and then there's some other lesions that look very suspicious, and then, so.
And you had lymph nodes in good places for bronchoscopy, so.
Okay, so I want to say something about the bus. It was 6:10. We'll be waiting for you. It's now 6 o'clock, so just a reminder. And is the... No, I have also 5 minutes here on the screen, so I'll try to... Okay, what is the most probable diagnosis in your opinion? It is multifocal cancer, lipidic predominant, it is lymphoma, metastatic lesions, or benign post-inflammatory lesions. there will be cardiac case, but I think we will start to. Okay. So can we go further? So this patient went to VATS surgery section, and there it was extranodular marginal zone lymphoma of the lung. And as a revision, I want to say about the BALT, which is bronchus-associated lymphomatoid tissue. This tissue is located in bifurcations of small bronchioles and also on the border of secondary pulmonary lobule, and that it's a kind of after the inhaled antigens, there is a reaction which caused the proliferation of these lymphocytes, and they could cause such lesions like that, because there is a near the bronchivascular bundle and could cause block the bronchis and cause the cyst. That's the reason why we can see like that. And my question to the panel, how often... What we did? Surgery 3. Yes, you... What we exactly? I don't remember. It was 2009. I was also working on that hospital, on that department now there. I don't know. Oh, okay. I was very young there. And how often do you encounter lung lymphomas in your practice or maybe in screening program? And would you choose a similar diagnostic pathway? This is my question to you.
Very uncommon, much less common than atypical infection or a multifocal adenocarcinoma. Would not have put this in the top of the differential, probably would have not even put it in the radiology report. That uncommon.
Yes, the only thing is I think that these are the things that you see on lung cancer screening and you know it's a positive, and then the patient goes for pulmonology follow-up. So I think that the diagnostic pathway would have not have been really different apart from the bronchoscopy. So I would probably first would have talked with my bronchoscopy department saying these are the lymph nodes, because probably that could have shortened the diagnostic pathway.
I've seen only 3 primary pulmonary lymphomas. They tend to be B-cell lymphomas and very difficult to diagnose. For some reason, even with EBUS, you have trouble with flow cytometry to pin them down. And both of the ones I remember, one was treated as a sarcoidosis and then just continued progressing and ended up being a lymphoma. And then the other one ended up in surgery because he had a very peculiar multifocal disease that we just couldn't get a hold of, and finally, after many bronchoscopies, and we ended up getting a surgical biopsy, and it was a lymphoma.
Okay, as an additional comment I could give you, it's that I recently was talking with a pathologist because we had one patient with Sjogren's syndrome, because the lymphomas are very, very probable in Sjogren's syndrome, and he told me that the best way is to resect one lesion, not biopsy, because we don't have such amount of tissue to prove lymphoma. So the surgery is a good option.